Hello, everyone. I'm here today with Dr. Lincoln Harris of Ripe Global. He likes to torture me to do it this time of night because he's in Australia right now. This is crazy. Everybody's
Hey,
asleep.
I would
You
have
and I
I
are
would have got
talking.
out of bed early. I would have got out of bed at 5 o'clock for you, Tom.
It's early over there, I can see, but anyways. Um, Lincoln, would you take a couple of minutes, give us a little background about you, who you are? Because, you have a huge following on Instagram. You have a huge following on Facebook. I've seen your cases. I've attended your lectures. But to be honest with you, before we met, I hadn't heard a lot about you. I was in my own little cocoon in a small town USA, just trying to be a regular dentist before all this Facebook group stuff happened. Take a couple of minutes, tell us about your background. Where were you educated? I know you've lectured around the US for a while. Give us a couple of minutes, would you?
Sure. So I grew up in Queensland in Australia. That's the top right corner, the bit where the Great Barrier Reef is. Obviously, because of the way maps work, Australia looks a lot smaller on a square map, and America looks massive because it's up near the top. To give you some idea of scale, the state that I live in is about 3 times the size of Texas.
Wow.
So, like if I start driving north, it's about 900, no, it's 1,000 miles to the top of my state from here. So, it's quite a big state. And then interestingly, the population of this state is it's less than Chicago. Okay. So you have that much space and that few people. So some of the things that I've done in my career are due to that issue. So I grew up on a farm. My parents were farmers. They went broke farming, and then eventually they moved into several different fields before they settled in where they are now. So, and then my entry into dentistry was I liked science at school. I didn't want to be a farmer because my whole growing up childhood was centered around slowly watching parents go bankrupt as farmers. So I wanted to do something that wasn't farming and was science-based. And I went to the dentist about like a week before we had to decide what we were going to do after high school. And I thought it was kind of interesting. He did fisher seal on something. He had this like light and shining out. I thought, oh, it's kind of cool. And so my sister was doing medicine. I said, what do you think of dentistry? She goes, they don't do after hours. So that was basically her recommendation. You don't do after hours, so therefore it's good. So she probably just done like an all-night after hours session when she said that. So I went into dentistry, and then I ended up with a practice at a little town called Bargara, which is so near Bargara is a town called Bundaberg, and Bundaberg is mostly famous for a town of 70,000 people, has the most famous rum in Australia, the most famous ginger beer in Australia, and now has an award-winning gin, like one best gin in the world distillery. So basically, we're a hotbed of cariogenic drinks and alcoholism. So, and that's because of the sugar background. So it's a tropical area. It was built on sugarcane plantation, and then it moved into ginger, and now we have sweet potatoes and macadamia. So all the sorts of things you can grow in tropical areas. Because it's remote-ish, like the nearest endodontist is 3.5 hours drive. The nearest periodontist that's full-time is 3.5 hours drive. I have a maxillofacial surgeon that visits the area once a month.
Wow.
There is local orthodontist. Orthodontists are, like the Chinese restaurants of dentistry. They always got in first into every single town in the world. And then, so because of that lack of specialist support, a long time ago, so this is how it started, and apologies to periodontists who are listening. In Australia, periodontists weren't trained heavily in the surgical side for a long time. It was more in the scaling and conservative treatment side, like their British counterparts. And so I sent a patient to get a soft tissue graft from a periodontist, and it was a complete debacle, and it failed. And so I'd been watching this fellow online for many times, and I thought, how hard can it be? Which is always the famous question that you ask before you discover how hard it is. And so I thought, well, I watched his cases. I know what he's doing. So I'd seen him do this soft. So I did a soft tissue graft after having watched many cases on the internet, and like not video, just the thing. And so that was probably the start of my multidisciplinary career. And then I went to the United States many times to get training with veneers, with rehabs, with implantology, with orthodontics, because one, I was keen, and two, I just didn't have good specialist support. And so at some point, because I have done this multidisciplinary thing for so long now, so since 2007, then a lot of people have asked me to treatment plan, help them teach treatment planning, because when you do all three major areas, your treatment planning gets quite efficient. And then from there, I started running hands-on courses in my office, actually due to the fact that my office was a bit quiet in 2013 after a big flood. So I started running some courses as a side hustle. Anyway, now the side hustle has overtaken the practice. And actually, it's got to the size where I'm almost not required anymore. So, like, I do teaching someone, but they could probably replace me easier than they could replace the executive team. So,
Yeah.
And so then we've got one thing led to another. And then in 2020, we did a capital raise, started a company called Ripe Global, which has kind of evolved very rapidly. But its purpose now is to work out where you are in your career, where you want to go, and how do we get you there as efficiently as possible, including every aspect of your clinical confidence and managing associates. And so whether you're a business owner or a dentist, how do we progress your career or your business as fast as possible? And we do that from a individual clinician. So the best way to build a dental business is you actually need to have really good, well-trained clinicians who are genuinely good at dentistry and know they're good at dentistry. And so that combination of those two things is what we have built a business on. And the growth, particularly in the last little bit since I met you, Bob, has started to get very exciting indeed. So
yeah, that's awesome.
Background.
Earlier this week, I actually interviewed Andy. The video is on our YouTube channel. It would be in the group soon as well. I was telling Andy that once I got to know you guys, I was so excited about this product because my whole career I wanted to do the pankeys, I wanted to do the pride and different comprehensive courses, but you have bills. You can't just close the office and go. And I kind of did not put enough importance on that. And this product is perfect. It's perfect because you can do it on your own time, on your own, basically your own equipment. That's the most important thing, because once you get used to the stuff that you're using every day, I can't even go to the next room, the next operatory, because I'm used to doing certain things in certain rooms. We're creatures of habit. So yeah, it's very exciting, and I know you've been. A lot of people in America know you, and I know our friend Matthew was telling me about some stories when you guys were here attending all these courses, continuing education courses. I don't want to say his last name just in case, but yeah. So tonight
Is that Matthew from Tennessee?
Yes.
Oh, you talking? Or Matt who lives in Chicago?
No, Tennessee guy.
Yeah. He's a funny dude.
Funny, yeah, he had some funny stories about, him and I have had interactions over the years, even though he didn't know who I was, on different forums. But tonight we're going to talk about some cases, right? I mean, kind of give us a little teaser into Ripe Global Teachings and what you guys do and how someone can improve their skills. And I was telling Andy that I feel like this is a product for everyone. If you are a new grad or an old guy like myself who still cries when he sees an MOD right next to each other, these are the improving your skills can actually not just help with your bottom line, help with your psyche, if you have less stress doing a procedure. So if you want to just take the helm and take us through your cases, we'd appreciate it.
Yeah, so we'll go through a few things today, but some of the things we'll talk about today are not really things that I would spend a lot of time teaching, but they're more examples of things that are surprising.
Mm-hmm.
So one of the things that has influenced me deeply is I attended a course with Heusler and Zuer. So not as well known in the United States, but they're amongst the most famous people in perioplastic surgery. So, fine, pretty gums, basically, surgery to make your gums pretty, and implantology. And so they were big into full arch implants back when full arch implants was first a thing, like back in the early 90s, late 80s. And then, of course, because they've been in the same practice for so long now, they're seeing like the results of all their work. And one of the things that's a bit daunting is watching all of your work wear out. Which is fine. But one of the comments they made, because they study the literature a lot, was that an implant has such a high survival rate that it equals a well-maintained tooth that's got periodontitis.
Mm-hmm.
Okay, so if you have a patient with periodontitis, even like 50% bone loss, and they have excellent management, an implant can match that survival rate, but no better. So what we see as an amazing survival rate of implants is actually the same as a patient with perio who's getting good treatment. Even patients who've got 50% bone loss, 60% bone loss, if they've got good management. So that sort of made me think a little bit that. And then the second thing they pointed out was there's some research that shows that dentists are extremely good at predicting how well healthy teeth will last. And dentists are very, very poor at predicting how long not healthy teeth will last. So in general, teeth will last, or in the vast majority of cases, teeth will last longer than we think, except for probably that patient that we promised that it definitely won't fall out when they're on their cruise with all their friends, or at the board meeting on Thursday night. So anyway, so I'll go through a couple of cases that sort of bring this to life, but we can talk again, Bob, on more regular things, and I can pull up other cases as well. But this one, I'll do this one first. It's kind of it's one of the first cases that really surprised me. So hang on, we'll go to this share here. I'm not using the full screen thing here because it's too much of a nuisance. It hides everything else. So this case here is interesting because this is how the patient came to me, and he was a very well-educated man, and actually had been an executive, went to periodontist every 3 months like he supposed to, knew his way around an interdental brush, knew what superfloss was, absolutely perfect. And so I'd be curious, like if you see something like this, what are you thinking, Bob?
I'm thinking, I'm reading patient does not consent to extraction, and I'm thinking he better not sneeze because that's gonna literally hit someone in the head, no?
Yeah, so he's one of those patients, these patients that don't want a tooth removed. So they grieve heavily about losing body parts, and that's fair enough. I probably would too. So he's one of those patients. So he said, look, the tooth I can bite on the tooth. It's not giving me any pain. I don't want it removed. And so I said, well, the tooth's hopeless. But obviously I couldn't take the tooth out without his consent because that would be illegal and also called assault. So yeah, I had no option, and I'll just show you like how okay, so that's how it presents. So, this is a patient who's been going to a periodontist pretty religiously, gets calculus pretty quickly, and so on. And so, I mean, there's a lot of things going on here. Obviously, he's got recession. His teeth don't look pretty, but actually, as far as I know, prettiness is lack of prettiness is not a sort of terminal pathology.
Right.
So, yeah. So, and really, it brings us to one of the most important things with treatment planning is who are you actually treating? Like, are you treating the patient or are you treating yourself? And so the reason this is important is because a lot of dentists project. They actually project themselves into the patient's situation. And they sit there. Like an example of this is when you're a new grad, a patient comes in with a broken tooth. So their tooth's off. And as a dentist, the idea of our central incisor being missing is deeply disturbing. Like we're mortified at the idea. And so then often when we start to develop our treatment for the patient, we're not treating the patient, we're actually treating how we would feel if we were in that situation. And then we do irrational things like, you know, put a post-core crown back into a split root because there's no possibility for us to do anything else that day. And of course, then it falls out and the patient thinks we're a terrible dentist. So the reason this case is interesting to me is, so that's 2009. That's 10 years later. So
Wow.
he's had 3 monthly perio every 3 months. He's had 3 monthly perio for 10 years. And now the tooth still looks like it would come out when he would sneeze. And I'm not recommending that people leave teeth like this in. Like I would have liked to cut the distal root off or something.
Mm-hmm.
But it's been 10 years. And so he finally came in and said, okay, now it's starting to get sore. And so the reason I like this case is because it reminds me that my predictive power is actually quite poor. And so then, well, what do you do with that? Well, I don't treat the patient, I don't treat the tooth, I treat the patient. And so one of the things we really want people doing when we're training them in Right Global is we want them to treat the whole patient. And I don't want to get into some like hippie, holistic nonsense, okay? Because like the holistic is a great word that unfortunately has been co-opted by alternative lifestyles for so long that you can't use it now without looking like a whack job. So we'll ignore it. But okay, you want to treat the person, not the teeth. So what does that mean? And like an example of that would be, I once had this 80-year-old who came in and she had a lateral incisor that was severely crowded to the palate side. And so when she smiled, it looked like she had this tooth missing. And every photo, she didn't want to smile because every photo, she looks like she got this black gap. And she was like 80, I don't know, 80 something, mid 80s. She goes, Link, I've hated this tooth all my life. I said, okay, well, we could do orthodontics. And she goes, I don't want orthodontics. I'm 85 years old. And I said, do you know what? She's right. And I extracted the lateral incisor, which was perfectly good, and did a bridge off her canine. That now, I'm not suggesting you extract crowded laterals and do bridges. That's not at all. What I'm suggesting is that everything that we do in dentistry depends. And the worst thing you can do is have a protocol that you put every single patient into, because then you've just got a protocol that you're forcing the patient to fit rather than finding out what the patient wants. So anyway, this case is interesting. Patient didn't want it out. I said that the tooth was hopeless and it would give him trouble immediately. 10 years later, he finally got the tooth out and got an implant, but he kept his own tooth for 10 years. So on the plus side, I still got to do the implant. And my implant has 10 years less to last. So chance of warranty claims is low. Right, I'll go to another one. This one's even more interesting. Okay, this fellow came to me. Okay, now this is from like 2012. So the photography is much less exciting than the photography I do now. There's his smile. What's your thoughts? What would you like to know?
Those were like composite attached to gold gold framework, right?
I think so. Yeah.
Yeah.
Yeah, something like that. Like he's interesting too, because he come to me and he says, I'm going to die soon. And you can see where he's had cancer removed. He had cancer in one of his saliva glands, so he's had a whole bunch of bone removed when they did the cancer treatment. Okay, so he's had cancer surgery, root canal city. It's got extensive crown and bridge work, which is all failing. And he says that he's not going to live that much longer. So I mean, what would you want to know from a person like this? And you know, what sort of initial thoughts do you have?
I'm gonna ask him, what would you want me to do? What's your chief complaint?
Yeah, so his main issue was he knew that his teeth were falling apart. And he says, I can't wear a denture. I've had a denture before and I just can't wear one. So if I end up with a denture, I just won't have any teeth. So that's where he was at. So the process that we go through is, and obviously the teeth were failing. He knew that they were breaking, you know, that they're all falling apart. So the process we generally want to go through is, first of all, what's actually your goal? So not so much the chief complaint, because complaint is what they don't want, but I want to know what they do want. And that's quite different. So chief complaint tells you all the things that you shouldn't do, but like the list of things that you don't want is usually quite large. So like all the places in the world that I don't want to go would be an endless list. The number of places in the world I do want to go is a much shorter list and probably a bit easier to deal with. So it's not so much what don't you want, is what do you want? And this is a tricky question because I don't know if you've asked patients this, but we ask them what they want. Sometimes they don't know.
Mm-hmm.
And the reason they don't know is because no one's ever asked them before. So if a dentist asks you what you do want, you're often confused. So the patients go, well, I don't know. I've never thought about that. And in particular, what they want long-term. And the reason why I ask that is because patients often, people, including me and you, we tend to think short-term a lot of the time, unless there's a good reason not to. And so the default setting is like here and now, you know, the default setting is Krispy Kreme donut, not celery stick and exercise.
Right. So did this guy just want that black spot gone?
He didn't want to have, well, he wanted to be able to eat without a denture. That's what he wanted.
Uh-huh.
And so, but the thing is, he's had all this treatment for cancer, and he's not going to live long, he says, because he's got like heart problems and his joints are going and he's got back problems and all of this stuff. And so I didn't really know what to do with him either. But I knew that I wasn't that keen on taking all these teeth out and doing a full mouthful of implants. And he wasn't keen on that either. And he didn't really want me to do anything on his lower jaw. So on the basis that he potentially wasn't going to live that long, I said, look, I'll tell you what, I'll dismantle everything and we'll have a look at what's underneath and see if we can build some sort of, build something on the teeth that you've got. So on that basis, we got in and we started to cut stuff out. And I think one of the things that's really important is that quite often you can't decide what to do with someone until you have a look. And so sometimes your treatment plan is a full set of temporaries and dismantle everything to have a look. Problem with that, there is a risk with this, and I have been caught with this before. So in 2007, I had a number of patients start treatment and they went into temporaries first. And then in 2008, the share portfolios all tanked and then they couldn't afford to go ahead. And so they were sitting around in temporaries for 3 or 4 years. And so you end up doing a lot of free temporary fixes because there's not much else you can do. Like you can't say, we're going to let your teeth rot because you haven't got money. Because most places in the world, if you do that, then you get sort of charged with, aiding damage to the teeth. So we took everything out, saw what was underneath, and tried to clean that up. So I mean, it was pretty wild this case because there was bits of core buildup done in amalgam, and there was pins and all sorts of things. Like it was pretty doubtful to my eye. So you can see that there's not a lot of tooth structure left here. But I went through the same thing that we teach all of our students. So step 1, dismantle everything. Step 2, clean it all up. Step 3, do core buildups, and then you can make a decision from there. Now, you can see that this last premolar on the upper left is like patient's left. Like this, that's definitely not the sort of thing that makes me feel comfortable is premolars like that have been root canal therapy treated. Anyway, long story short, we got the patient into temporaries, and then we made him a full arch prosthesis with stress breakers. So there's actually the posterior sections went in first. So the two back teeth, and then on the upper right, patient's upper right, and then the two teeth on the upper left. And then the front section went over the top of that. So the reason we broke it up is obviously it's quite easy to get like a 2 or 3 unit prosthesis fitting really well, but getting a 11 unit prosthesis to fit really well, particularly back then, because they weren't milling things back then, they were casting, and casting metal over that length, you get so much contraction as it cools, and then you get distortion as you bake the porcelain as well. So trying to do a full arch roundhouse, which you see coming out of often, poorer countries, is pretty difficult to get things fitting. So we did this in sections, and also then you get a little bit of movement if you need to, and it doesn't stress out the cement on any individual tooth so much.
So you have, when you say stress breakers, where are they separated?
So they're separated. So this section here is one piece, I think, up until the lateral incisor, one side of the lateral incisor, and then the central section over to the canine, and then the posterior teeth were one section up to the canine. So the posterior section went in first, and then the canine went over the top.
So is this like male female type of thing,
yeah,
that they sit on top of each other?
Just a slot, it's like a milled, it's like a milled slot with a, I don't know. I don't even know the names of them. So the funny thing is, Bob, that I learnt this stuff from Dental Town because no one teaches it anymore.
Mm.
So, so this is a stress breaker case. Now, probably we're just about done with these sorts of cases these days because the technicians don't have the skills, and when you go to milling units can't do a lot of this stuff. So I don't, but that's not really the thing that's interesting with the case. So I did this. This was in 2012. Okay, it doesn't have that good a posterior support. Okay, and eventually I did some implants on his lower right, and then I just saw the patient recently, and he had loose teeth. Okay, I'll just go over to these pictures, which I took recently. So here we are, 10 years later, 11 years later. Okay, bit of wear. He goes, Link, these teeth on the right-hand side, they're jumping in and out. Okay, now it can't come out because the male portion of the stress breaker is on the 3-unit posterior bridge, which is the bit that's fallen out. And so we can't, we can't lift it out. So we've got to cut it. So anyway, we cut that out. This is what's left. So the posterior tooth is still fine. The premolar, which had almost no ferrule to start with, is actually fractured off. And you can actually see, if I zoom in, just bring that down. You can actually see the little attachment on the back of the canine there. Yeah. So this is 11 years later in a case that I had bad feelings about it, and so on. And so I don't want anyone to take the wrong message out of this. The wrong message would be that it's okay to do things that give you bad feelings. And I definitely don't agree with that at all. But what is interesting, and so then I bonded that section back in, and we'll probably do some implants there. But there's two things that have really struck me through my career. The number one is how long teeth that you think are hopeless last when you do nothing. So I'm not saying that you should do nothing. I treat a lot of teeth, but with effort and hell, teeth can last a really long time. But even more important is how long patients last. Even patients who say they're going to die, they all threaten to die on you so that they don't have to do their teeth. And they frequently don't. So like this, one of the most difficult things in dentistry is that patients don't die on time when they're supposed to. And so, they live on and on and on, and they've got multiple medical issues and they live on and on. Now, you've been in practice for a long time, haven't you? Like you've had the same practice for how long?
I've been in the same town for 30 years.
And so you've had the same practice, I take it, for 30 years as
Yes.
well. So
Yeah, I mean, I've worked in it for 9 years. Then the guy retired, and I bought him out. So I've been an owner for 21 years.
Mm-hmm. So, like, what's been your experience with patients that maybe you started the practice, they were 60. Okay, so 30 years ago they were 60. Okay, and I'm sure now you still have a lot of those patients in your practice.
Yes, absolutely. I just posted one that this lady who's 93 years old, and every time she drives there, and I told her, please, don't stop to buy flowers. She buys me flowers and brings it to the office, and I'm thinking every stop with this car is an added risk for her. Like, just come to your appointment. You don't need to. She goes, oh, I'm going for shopping anyways. But yeah, she's been coming to me for 22 years.
Mm-hmm. Yeah.
And I done some crowns on her, and I kind of like felt guilty. I'm like, this is like 10 years ago. I did 6 crowns for her on the top because she wanted it. She wanted it to look better. And I was thinking to myself, oh my God, what happens if this lady passes on and she's still going?
Yeah, and then the patients, I'm sure that you've had the same, but I've had some patients pass away, but they're not always elderly.
Mm-hmm.
They're often so this is a very awkward story, okay? Because I always feel guilty when I tell it, because I was happy but sad at the same time, and I was happy in a sort of slightly inappropriate way. So I have this patient, and this was in my early career of doing rehabs, when I, at the time, was what I would say full of confidence that was beyond my level of ability. And so I was very confident that I could do rehabs. I wasn't yet competent, but sometimes you don't know that for some time. So I get this guy, and he's traveled, and it's like the ultimate ego stroke. And this is where it's very dangerous in dentistry. There's 2 types of patients that will stroke our ego, and they're both very dangerous. The first one is the patient that travels a long way to see us. There is nothing that you want to put on the gram like, oh, this patient traveled from another country to see me, because the other 7,000 dentists that he flew over, none of them match up to me and my massive abilities. Okay. So that's dangerous ego stroke number 1. And then ego stroke number 2 is treating another dentist. Like, if you want to make 0 profit, treat another dentist, because when you're treating another dentist, no matter how much you charge them, you will spend 4 times as long doing a single surface composite as it would normally take to do a full mouth rehab. Like, you will be sitting there with all your have your like French artist hat on, your beret, and you'll have like your palette and all your brushes, and you'll be sitting there like stroking the composite lovingly into shape, putting the tertiary anatomy on it so that it looks like the day that God made it erupt through the gum. Okay, and then after you finish this, you'll be made about $12.20 per hour plus tips. And so this will be the second dangerous ego stroke, is treating a dentist. And of course, you want to put that on Instagram too, because the fact that you are the dentist goes to, means that, like, literally, when I walk to work, the heavens open and a sunbeam comes down, makes my hair illuminate. Okay, so anyway, so this was ego stroke number 1, which was the patient who travels a long way. Come from, I remember the town, it was Helidon, which will mean nothing to your viewers, but it's, I was going to say 500 kilometers, that they won't know what it is. It's 5.5 hours drive away. Mm-hmm. On country roads, there's no interstate type highway between here and there. It's all like windy 2-lane road with kangaroos that jump across randomly and try and impale themselves on your radiator the way deer do. And so we get all the same problems with kangaroos that you get with deer. It's just that you think they're cuter because you're not used to them, and we think deer are cuter, and you think deer are a pest that eat your carrots in your garden, and we think deer are cute. And actually, basically, a kangaroo is a deer. Okay, so like they're special to you because you've never seen them. To us, like I go past several, and if they go into your radiator on a long drive, then your car stops. So anyway. Comes 5.5 hours. I do a rehab on him with a lot of confidence. And then about 2 months later, he calls me up and goes, hey, Link, one of the crowns has fallen out. Now I know that you can't bond to zirconia after you've contaminated it with phosphoric acid. But this wasn't well known back then. And I'd used Panavia to bond all these zirconia crowns in, and no one knew how to bond zirconia in those days. So I say, okay, come over. He comes over, and then we fix that. And then he comes back. He calls me up about 2 months later. Hey, another one of those crowns has come off. I'm like, oh, shivers. Now all of my excessive confidence is coming home to roost. So I say, come over. And I'm sitting there going, I hope, like I'm just starting to imagine the 28 crowns are going to fall off one by one, and he's going to go to someone else, and I'll have to refund him all of the money. And I was feeling poor at the time anyway. That's danger zone number 3, is never do a case that you can't afford to refund. That's like the ultimate test. If you can't afford to refund the money, you shouldn't do it yet. Now, bear in mind that you and I have both broken that rule multiple times early in our career. So don't do as we did, do as we say. So anyway, then 2 days before his appointment, his wife calls and says he's dead. He just had a heart attack and died the other day. Oh, God. Like, I have never had such guilty and conflicted feelings in my life because he was a really nice guy. And I felt really, really sad that he passed away. And I also felt very, very happy that none of my crowns were going to fall off. And so to this day, I don't know what I'm supposed to feel here. I still feel conflicted inside about the fact that I was glad and sad at the same time. So he was 54.
Wow.
So, you know, like the patient, you go, oh, well, I'm 60 and, you know, I'm worried. Like most of the patients where I've done a rehab and then they haven't got their money's worth out of it, just unlucky.
Right. Unlucky. Yeah.
So I think that now every single week I would hear someone say to me, well, I'm 75, maybe it's not worth doing my teeth. Do you hear that?
All the time.
What's your answer?
I tell them, listen, they've got good drugs these days. They won't let us die. We're going to run out of money before they let us die. And I tell them the examples. I have patients that I have a patient that's 101 that passed away a couple of years ago. You know, it's you never know. You never know how long you're gonna live.
Mm-hmm. Yeah. So that's I had this beautiful patient that I treated early when I first opened my practice in 2000. So I graduated in 1998, and then I worked in a government clinic for 1 year in a remote area for 1 year, and then I moved to another government clinic. I had to work 2 years in a government clinic because I needed a government scholarship to help afford to get through dentistry. And so the second year, I started my practice as a side hustle. So you can see I've got a bit of a trend here. So I started a practice. I found an empty shop, started a practice as a side hustle while I was still working at the government clinic full time. Mm-hmm. So I did nights and weekends, and you know, acted like a person who is a workaholic. Clearly, I'm not. So I started this practice, and there's a beautiful lady. She came to me. She was one of my first patients. She's just the most lovely lady. Her husband was a pastor. She was just so gracious. And over the next 15 years, I did a bunch of crowns. I probably did about 10 crowns for her. It's a lot of money for her. Like, they didn't have a lot of money. She lived until 2 years ago. So she was 74 when I started treating her, and she was 96 when she passed away. And I treated her up until she passed away. When she was 92, she said, Link, when I did those crowns, I wasn't sure I could ever afford them. But she says, looking back now, I could easily have afforded them. I've still got money left. She says, but if I hadn't done them now, I wouldn't be able to get that done now. I'm not strong enough anymore. So for the last 8 years of her life, she didn't need any dentistry because it was well done up to that point. And we'd done some proper things. And for the last 8 years of her life, I don't know I could have done a crown because she was frail little lady. She was hunched over. She had a stick. We had to help her up into the chair and so on. And so she wouldn't have, if we hadn't done good work, she would have had teeth fail. And so the thing now is that people get given this idea from society that they're no good once they're 65 or 70. They're not worth, and if you're in public health administration, maybe that makes sense. Like if you're in a government department that dishes out money to people and you're going, well, do I give it to a 23-year-old with all this economic potential, or do I give it to a 90-year-old who might die soon? Then sure, that's a decision you can make because you're dealing with public money. But when you're in private practice, you're not dealing with public money. You're dealing with the person's money who they can spend however they want. And often these people are beat down, like they've been told that they're useless, they're no good, you know, oh, you're too old for that. And even dentists sometimes say, you're too old for that. Why are you bothering fixing your teeth at 75? So this is I don't know about you, but dentistry, the growth in dentistry is extraordinary. Not because population's getting bigger, it's just that population getting older and older, and they don't want dentures till the day they die.
Right.
Yeah. And if you work out how to communicate that to people and give them that hope, like, and actually, I don't even let them have that mentality. They come in and go, oh, maybe I'm too old for this. I go, listen, you're 70, you've got a clean medical history. Your chance of living well into your 90s is actually over 85%. That's just statistics. Like, and because like the average age in Australia is like 80, for men's like 83 and for women's 84 or something. Okay. But see that includes all of the 15-year-old men who kill themselves doing stupid stuff on motorbikes. Okay. And then all the people with genetic stuff that get taken out early in life. Okay. And so if you get to 70, if you get to 70 and you've got a clean medical history, your chance of going well into your 90s, almost to 100, is really, 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 really high. So that's like 30, well, nearly 30 years. Most of the dentists who listen to you haven't done dentistry for 30 years. You've done dentistry for 30 years in one clinic. That means that, like, if you saw a 69-year-old, you might still be treating them.
Absolutely.
Yeah. So, I mean, that's just, I see people who are always trying to market to like the Instagram, influencers. And like, I want the oldies, They've got 65 years of damaging their teeth to fix up. And they've also got, often 45 years of compounding growth of their assets. And that is a match made in heaven.
Right. And basically, it's a really interesting point you bring up, that you need to, and everybody I'm sure has this experience that, our parents, my parents are getting older, my wife's parents are getting older. It's very difficult to get them into the dental office.
Mm-hmm.
And, my father-in-law is 94 years old, doesn't get out of the house anymore. What happens? I've bought some SDF and some micro brushes. I go there, brush their teeth, and put some on the decay. So yeah, it's a good point, and I'm going to use that. It's a good little gem.
Well, the philosophy in our office with elderly people, or retired people, because they're not often elderly, but is keep as many teeth as possible in as good a condition as possible for as long as possible. Because there is a period at the end of your life where you can't get dentistry, and it's often like 5 to 8 years long. And you want to enter that period with like 28 teeth that are in good condition, so that as you start losing them, you've still got plenty left.
Right.
Because, and like, who wants to get dentures at 90? Like, your adaptive capacity at 16 is great. Like, the old people who, back in the 40s where they got all their teeth out at 16 for cosmetic dentistry, sure, you can adapt to anything when you're 16. You've only had teeth in your head for 10 years at that point. Whereas when you're 80 or 90, very difficult, very difficult.
Right. right.
There's one more case I'll talk about. I don't need to show you, but it's a patient I did 14 units of ceramics on just for cosmetic purposes. Got that patient back 10 years later, hadn't done a single bit of dentistry for her. And that was when I realized that well done indirect dentistry lasts a really, really long time, and patients like not having any maintenance for a long time. Well, she should have had maintenance, but she didn't. That was her choice. But she had nothing go wrong for 10 years. And so then I've realized we've got this sort of dental nihilism or just generalized low self-esteem in dentistry, where we're constantly told by people who don't actually do much dentistry but read a lot of papers that dentistry is bad for patients, and that dentists are bad for patients, and that we don't do any good and we do damage, and the more that we touch the tooth, the worse it gets. And if you get a pulp exposure, you should be sent to hell, and all of this like complete nonsense. And then I look at these cases and I go, this patient, it's changed their life. Like, she didn't smile before, like ever. And so people thought she was grumpy, and no one was nice to her because she was a grumpy person. But she wasn't grumpy. She just had bad teeth. And then, like, for a decade, she's had nice teeth and she hasn't had to have anything done. Like, that's amazing. Like, short of what else can you do that's that powerful? Like, maybe make someone a prosthetic nose who's had their nose cut off from cancer. Like, that's literally, and no one says, well, that's a bad idea, and it's just cosmetic to be able to not see into all your nasal passages. Like, that's disfigurement. So, like, as dentists, what we do for people is amazing. And I get so sad when I see all these dentists going, oh, well, And so, I mean, part of it's, I think, our training. Like, we're not confident that if we do something, it will actually work, because we don't know whether it will work, and we're not trained properly when we graduate. And so then you can't be confident about something. You can't be confident to look the patient in the eye and go, hey, you should do this, because you go, I have this doubt actually whether it will work. I was talking to a dentist the other day, and she said literally before she started doing the Right Global restorative course, that she would basically live in fear of having to do a procedure, and she would just avoid talking to the patient. So she'd have to call them back about the treatment plan, and she would avoid talking to them because she was so scared of the procedure that needed to be done. And then she's gone from there, like, she was afraid of crowns, and she's gone from there to doing like 10 or 15 a week, from literally 0 to 15 a week. And she's a second year out grad. So, like, she's starting to see that what we do for people is amazing.
Yeah.
Yeah, it's pretty cool.
Yeah. When I was in Philadelphia, you talked about something that was very interesting, because I practiced a little bit differently than what you were saying, and since then, and this was back in, I think, April, we were all there. You were talking about presenting a treatment plan and not to confuse the patient too much with too many options, and tell them what they want, what it's right, and do the right thing. Can you elaborate on that? Because I think it's a really good subject, because I am famous for confusing my patients by giving them all the option there are, and all these law cases that come in and train you that you're supposed to present with everything. But it was a breath of fresh air when you were talking, and I was quite intrigued.
So, well, I guess probably before I say that, what's been the effect of you actually making a recommendation to a patient?
Say that again, I'm sorry.
What's been the outcome for you when you actually make a recommendation to a patient, as versus just generically give them options?
I'm just so trained. My mind is trained for so long by giving all the options, such as doing nothing, that I've been trained to basically believe that this is the right way of doing things, and it is practicing defensive dentistry.
So it's okay to give them options, and I also give them the option of doing nothing and other things, but I always recommend one of the things.
Yeah, I do that too. I do that too. I should not say that I don't. I tell them this is the best way. This is the Cadillac, and if you want a Toyota or a bicycle, I can get you that too. So
yeah. So you recommend that this is
yes.
what you should do. This is the thing I can do, but this is what you should do. That's so. So the great myth is that if you give people options, that it protects you legally. And any medico-legal expert will tell you that that's not true. Because if they choose an option that doesn't work, then a patient in almost every modern Western country is not allowed to, a patient cannot consent to bad treatment.
Right.
So you can't offer anything that's bad. So you can't go, would you like to have your teeth scaled or have a crown on all your front teeth? Okay, because like if all they need is their teeth scaled, then crowning all their front teeth is completely irrational, and there's no defense for that treatment because it's inappropriate and everyone knows it. So where this is most common is with the broken back tooth. You've got a cusp off. Now, every dentist I know, when you've got big MOD amalgam and you've got a cusp off, will offer some type of ceramic or gold option and a composite resin. But mostly the way they present it is if they're all equal. They go, right, so you can have a ceramic restoration. It's stronger, probably lasts longer, but it's going to take longer to do and it'll be more expensive and it'll take 2 visits. Or you can have a composite resin. It's not as strong, won't last as long, but it'll be cheaper and faster to do. Or you can do nothing and leave your tooth broken and then it might fall apart or it might not. So they do something like this. So you've presented all of these options as if they're equal, and one of them is cheaper and quicker. Now, any sane person, if you present a bunch of equal options, will go, I'll have the cheaper and quicker one because it sounds like they're all the same.
Yeah.
But the thing is that no dentist recommends gold or ceramic unless they're a complete shonk, okay? And I don't know if that word translates into American, but, you know, shonk, there's a Jewish word for this type of person. You know, I can't remember it. Anyway, people who have sold their soul on eBay for a good price, or even a not so good price. So, but most dentists want to do the right thing. If they don't do the right thing, it's usually because they lack self-esteem or training. And so they want to do the right thing. And so they're going, you should do gold or ceramic because they actually think it's the best. They don't offer that. You don't go like, would you like a single surface composite or a crown? They never offer it in that situation, and neither do you. So here's the thing, like you go, I always offer options, but then if I say to you, okay, they've got like a class 1 cavity, what are you going to do? You don't give any options. You go do class 1 filling. That's it. Okay. And you can do it in my preferred material. I'm not even going to ask you which one because I like amalgam or I like composite. But that's it. Okay. So when it's small things, you're all like, oh, I don't give options anymore. So, but when it's a big thing, you're going, would you like a crown or an onlay, or would you like a composite resin? Clearly, the only reason you're offering the crown or onlay is because it's the best option. And so don't present it as equal. You present it, this is what you should do if you can afford to. Not it's the Cadillac or the Rolls Royce, because then it sounds luxury. And it's not luxury, it's just the best treatment. So if you can afford to, which is, you know, you need to be sensitive to people's budgets, because the best way to really annoy someone is to make them feel poor and feel bad about feeling poor.
Mm-hmm.
You know, like when I was a student, I went into a car dealership and they wouldn't let me sit in the car because I was a student. And like, I would never go to that car yard even now. I wouldn't go in there to put the fire out if it was burning down. So, so instead of going, you know, this is what I teach my students. If you've got a broken back tooth, tell the patient, if you can afford to, do ceramic. If you can't afford to, we'll do plastic. Ceramic's better. End the story there. And their treatment acceptance rate usually triples or doubles when you stop faffing about and going, oh, well, let me confuse you with a dental textbook. And then because you're so confused, you'll go to the default option, which is cheap and quick. So that's the thing. And in general, if you can't make a recommendation of what's the best treatment, then you haven't asked the patient enough questions. And it's uncomfortable. Most people find it uncomfortable to make a recommendation because the first time they do that is the first time they realize they actually are responsible for the decisions that they're making. and there's no way to get rid of that. Giving patient options doesn't take away your responsibility as a practitioner. So if you're going to be responsible and you have to put your name to something anyway, you may as well choose the one that you think is best. And most law cases are not because someone did an expensive, well, they're either expensive thing that went wrong, but most commonly it's actually compromises, where the dentist compromised. Where they said, oh, well, it's not as good, but we might try it, and then it doesn't work. And then the patient goes, well, if you told me it wasn't going to work, I wouldn't have done it. I would have done the more expensive thing.
Right. Exactly.
Yeah. Anyway, so I've got to run off and do some implant training, but Bob, if people can submit cases on dentistry in general, you and I can sit and chinwag about it and maybe give them some help. So that'd be cool.
Yeah, that would be great. I'm gonna promote it a little bit, and that would be nice to go over some cases. And I have some cases as well, except you sent me something that I got nervous, and you said, well documented. You want me to take really good pictures so you can. So I got to get my stuff out. Otherwise, I did have some cases. And I'm like,
well, documented just means you got a photo. Don't just send me a bite wing.
Exactly. I want to thank you for spending this time with us. I don't think people realize that you're reading all these comments and looking at the pictures. So if you have a case, people post it and tag Lincoln, and we can all go and dissect them. Again, thank you very much, and hopefully we can see you soon.
Yeah, I look forward to it. Actually, I plan to come over in October, so I'll talk to you about that soon, about maybe doing something in Chicago, because I'm going to be in Michigan anyway. So
yeah, don't ruin the surprise. I'm working on it.
Okay, forget everyone who heard that. Nothing. Don't be curious about what's happening. It's none of your business.
Exactly.
Right. Exactly. Now that we've put that fire to rest, I better move along. Thanks, Bob.
Okay, take care, Ed.